Good evening, everyone. It's a pleasure to be at Tata Memorial Hospital. Thank you, Dr. Bhavna Sirohi. So the topic I've been given today is my top 10 strategies that I would advise for choosing wisely in breast cancer. And this is the list of my 10 favorite topics. I'll just go through them in brief. So starting with screening breast cancer, mammographic screening is not ideal for India or other low middle income countries because of its cost and complexity. So we have to look for a more cost effective method. And this is put forward very nicely in this paper by Tata Memorial, Dr. Barve's study. This study for clinical breast examination, this was a prospective cluster randomized trial. 20 years was the duration, and there were 20 clusters, 10 screening, 10 control, 151,000 women. That's a huge number. And the results showed that there was a significant reduction in stage 3 and 4 disease, 37% versus 47%. That's huge downstaging. There was also overall breast cancer mortality reduction of 15%, but this was not statistically significant. But what was important was that there was a 30% relative reduction in women more than 50 years. This is almost equivalent to the mammographic screening trials that were earlier done. Hence, the recommendation would be that clinical breast examination should be considered for breast cancer screening in low and middle income countries. Coming to the next strategy that I would like to propose is axillary sampling. Again, another paper from this institute by Dr. Vani Parmar et al. Now, why this technique? Because nuclear medicine is not available in all the hospitals in India. In fact, majority don't have. And as a result, all the women end up having a lot of axillary morbidity after the axillary dissections. So we don't really need to do a sentinel node biopsy for all these node negative patients. This was shown in this paper. And as you can see, for primary operable breast cancer, the early breast cancer patients, the false negative rate with lower axillary sampling was 10.5%, whereas sentinel node biopsy showed a false negative rate of 12.7%. The negative predictive value was equivalent for both. So this study showed that lower axillary sampling was equivalent or not inferior to sentinel lymph node biopsy. They took it a step further and checked this lower axillary sampling versus sentinel node biopsy after post neoadjuvant chemotherapy. And even in this paper, if you see the comparison of the false negative rate, in lower axillary sampling, it's 9.9, and in sentinel node biopsy by the radioactive technetium and the blue dye, plus palpable adjacent nodes, the FNR was 19.7. That's quite high. And if you remove the palpable adjacent nodes, it was only sentinel node biopsy only, then the FNR rose up to almost 31%. So this clearly showed that actually lower axillary sampling was not only equivalent to the sentinel node biopsy, but actually it was superior to sentinel lymph node biopsy. So it is a reliable, reproducible method, especially because it gives the directions to dissect in a very limited area with very clear-cut anatomical boundaries. Hence, the surgeons can learn this and easily reproduce it in all the centers, all the cancer care centers, and a nuclear medicine department is not really required. That would be a really great change in the management of these patients. Now, coming to the next strategy, IHC4. This was a paper by Jack Cusick et al. In which they compared the genomic assay with IHC4, the information, a prognostic model was created and assessed and further validated. And the conclusion was that prognostic information by IHC4 assay is similar to the genomic recurrence score. I'm sure many of the medical oncologists over here are already using this in their clinical practice. Now, the only issues with this is that there is a lack of reproducibility of the IHC assays. It's not possible to do it in every lab. However, we are already doing ER/PR, HER2/neu routinely in all the labs for treatment of breast cancer. So these three remain the same. And there is standardization for these three. It's only the Ki-67 which needs some better standardization across all the local laboratories. So that is already under process, and there are many guidelines, the ASCO cap and the UK guidelines for this. And I'm sure this issue will get sorted out and we will be able to use IHC4 more. Now, coming to another surgical technique, which I feel is an alternative to acellular dermal matrix in breast reconstruction. Now, acellular dermal matrix has been used widely in Western countries, but it's extremely expensive and not at all available in India. We can't use it, and the rates of breast reconstruction in India are less than 3%. So to increase these rates, this would be a good technique. And this was first described by Dr. Mark Lee from Australia. And he used this scarless LD, means the latissimus dorsi flap is actually harvested from the anterior approach without a scar at the back. And this increases the operative time by about 1 hour. And there is no scar at the back. The pain is also less. Several studies have been done on this technique. And many authors have even reported that the whole of LD can be transposed anteriorly and the implant can be covered by this instead of ADM. So this is an easy technique to learn. It is reproducible. It is cheap, especially useful for low BMI patients where autologous tissue is not present for reconstruction. And of course, it has reduced rates of complications as compared to ADMs. And most important, the breast reconstruction rates can increase in India with this. Coming to next strategy, 6 months versus 12 months of adjuvant trastuzumab. There's been a lot of debate and discussion on this in all the conferences and all. Several meta-analyses have been done. This is one by Huan Deng, and it says that 12 months trust, DFS and OS was marginally better, but not statistically significant, and more adverse effects in the 12 months group. Another one by Seema Gulia et al. Again, comparing the shorter duration with the longer duration. And this also showed that the DFS was equivalent to that of 12 months and overall survival was also equivalent. And it was non-inferior to the 1-year duration. Now, this I feel could be game-changing strategy because the financial toxicity is a lot with trastuzumab. Many of our patients simply refuse to take it because of the duration. So 6 months being proven equivalent to 12 months, this would really help out a lot of our patients. And I'm sure it's already being started by the medical oncologists. So coming to another strategy, addition of carboplatin to neoadjuvant chemotherapy for triple-negative breast cancer patients. This was shown in this trial, and there were 3 arms, and you can see the difference. The Paclitaxel carbo plus and minus veliparib in the upper 2 lines, and there's a lot of difference with the lower graph, which is without carboplatin. The event-free survival was 10% better in the Paclitaxel carbo group plus minus veliparib, but there was no difference in the overall survival in the 3 arms. Another study, the results from JEPAR 6-2, that also showed that carboplatin improved the DFS as well as the overall survival in TNBC. So this is again, I would say, a cheaper alternative rather than adding pembrolizumab and other fancy drugs, and more cost-effective also. Coming to the next strategy, which would be fast forward. The 5-year results have come out, but the 10-year results are still awaited. Not everybody is doing this strategy, this method, but it is has been proved to be a reasonably good technique for patients. And our patients, when we started doing this in the COVID times, they were very helpful. I mean, they were really helped by it, and they were all very happy. And many of them still ask for it. You know, they've heard about this 5 fractionation technique, and now when you recommend the standard 15 fractions, they ask for the shorter therapy. So the radiation oncologists in our hospital take a call on this, whether the patient is suitable enough to undergo the fast forward or not. But this would be a very useful strategy for the patients in India, because it's not only the cost, it's also the convenience of coming to the hospital lesser number of days. Coming to this has also been discussed several times. Single agent injection progesterone, 500 milligrams intramuscular, given 5 to 14 days before the surgery. And 1,000 patients, you can see that the 5-year DFS and OS for all patients was equal in the test and control arms, but the 5-year DFS and OS for node-positive patients was better in the progesterone arms. So this was actually a hypothesis-generating study, and it gives a lot of scope for us to use just a very simple strategy of giving this single injection and improving the survival of the breast cancer patients. Coming to another one, a metronomic methotrexate and cyclophosphamide after the adjuvant chemotherapy in triple-negative breast cancer patients. This is a very short and sweet study. Treatment protocol was after completion of chemotherapy and adjuvant treatment, addition of cyclophosphamide and methotrexate for 1 year. And you can see the DFS and the OS graphs. So these patients definitely did better if they received the metronomic chemotherapy. Again, methotrexate and cyclophosphamide are low-cost solutions, and if they can give this much improvement in survival, they are definitely worth it. The toxicity also was not increased to a significant degree. Hence, it was concluded that extended adjuvant metronomic chemotherapy achieved significant improvement in DFS and OS in triple negative and is quite well tolerated. Of course, we need more trials and more info on this. And last but not the least, I would like to touch upon this. This was recently presented in ESMO by Dr. Bardway. And this is a very simple technique, just giving peritumoral injection xylocaine during surgery, and just see the graphs, how they are diverging. There is 26% improvement in DFS by giving this injection, and deaths improved by 29%. That is a huge benefit to be achieved by this simple technique. And obviously, it can be implemented globally, and it has the potential to save thousands of lives every year. So thank you so much.